The human abdomen is not a solid block of packed tissue. Structurally, it is organized around a hollow, specialized space. This is the peritoneal cavity. It is a narrow gap bound by the abdominal wall on the outside, wrapping tightly around the internal organs on the inside. In its healthy baseline state, this cavity is completely sterile. It is a sealed environment, naturally devoid of any bacteria, fungi, or external microorganisms. Millimeters away lies the gastrointestinal tract, which holds trillions of microbes. Abdominal health relies on keeping the structural barrier between that densely populated gut and this sterile void completely intact. When that barrier fails, the resulting acute inflammation of this normally sterile space is called peritonitis. When a patient presents with peritonitis, the physician must determine the exact mechanism of the breach. Medicine organizes peritonitis by etiology, or origin, dividing the pathology into 3 specific classes: primary, secondary, and tertiary. Identifying the correct class is a practical necessity. The origin of the breach predicts which specific bacteria are multiplying inside the cavity and determines the next step in clinical intervention. Secondary peritonitis is the most common presentation encountered in clinical practice. This occurs when there is a macroscopic physical tear in the gastrointestinal tract, such as a burst appendix, a perforated peptic ulcer, or a ruptured diverticulum. When the intestinal wall physically tears open, the contents of the gut spill directly into the sterile blue peritoneal cavity. Because this fluid contains the unfiltered spectrum of intestinal flora, the resulting infection is inherently polymicrobial. Multiple strains of bacteria flood the space simultaneously. The patient's physical presentation reflects this biological insult. They develop a severe acute abdomen, marked muscular rigidity, and rapid progression into systemic shock. Structurally, this breach can remain confined to one region, presenting as localized peritonitis, or if an ulcer spills freely, it causes generalized peritonitis, spreading the infection throughout the entire cavity. Secondary peritonitis represents a catastrophic structural failure, requiring immediate mechanical or surgical intervention to close the hole and wash out the cavity. When a surgeon enters the cavity, the chemical and physical makeup of the leaked fluid, or exudate, points to the organ that failed. Finding thick bacterial pus indicates purulent peritonitis, a sign of an active, localized bacterial infection. If the fluid presents with a distinct feculent odor, the diagnosis is fecal peritonitis, which indicates a perforation in the lower bowel. Alternatively, the initial fluid might lack bacteria. Leakage of gastric acid, pancreatic enzymes, or gallbladder bile causes chemical peritonitis. These substances are sterile but highly irritant, triggering severe localized inflammation on contact. Analyzing the physical profile of the exudate acts as a diagnostic map, guiding the clinical team to the compromised organ. Not all peritonitis requires a physical hole. Primary or spontaneous peritonitis occurs while the gastrointestinal tract remains completely intact. This class targets patients with altered internal fluid dynamics, specifically children with nephrotic syndrome and adults suffering from liver cirrhosis. In a cirrhotic patient, a pool of fluid, called ascites, gradually accumulates in the peritoneal space around the organs. Without a macroscopic tear, microscopic bacteria migrate across the intact bowel wall directly into the ascites fluid. This is spontaneous bacterial translocation. Because this mechanism requires specific microbes capable of slipping past mucosal defenses, the infection is typically monomicrobial. A single pathogen class dominates, most commonly E. coli, Klebsiella, or Streptococcus. If a cirrhotic patient with known ascites develops a sudden fever and abdominal pain, the immediate clinical suspicion is spontaneous bacterial peritonitis. Unlike the mechanical rupture of secondary peritonitis, primary peritonitis is a systemic failure of fluid dynamics and local immune defense. Even after an initial infection is treated, the sterile cavity can remain compromised. This creates the condition known as tertiary peritonitis. This is defined as a persistent or recurrent infection that survives despite adequate medical or surgical therapy for the initial event. It almost exclusively affects the critically ill, the immunocompromised, and individuals enduring long-term stays in the intensive care unit. Look at the peritoneal cavity after a surgical washout. The dominant bacteria from the initial breach are gone. But in the recesses, isolated, muted microbial particles remain, multiplying without opposition. These survivors are opportunistic, low-virulence organisms like Candida, Enterococcus, and Staphylococcus epidermidis that exploit the patient's exhausted immune system. The initial surgical problem has been resolved, but the clinical focus now shifts to managing these opportunistic pathogens within an environment where the body's natural defenses are failing. Most peritoneal infections are explosive and acute. However, a select few specialized pathogens generate chronic, slow-burning peritoneal inflammation over a span of months. Tuberculous peritonitis is the classic example. It is a chronic granulomatous infection occurring in patients with systemic tuberculosis. On physical exam, this pathology presents with a distinct doughy texture to the abdomen upon palpation. Identifying that doughy texture allows the clinician to initiate the targeted infectious disease therapies required for tuberculosis, rather than proceeding with acute surgical protocols. These distinct origins can be distilled into a functional decision matrix for diagnosing the acute abdomen. This chart breaks down the etiology into three main classes: primary, secondary, and tertiary. Secondary peritonitis is the most common presentation, caused by a microscopic cystical breach of the GI tract. Primary peritonitis occurs with an intact GI tract, occurring in the presence of liver cirrhosis, ascites, and a monomicrobial infection. Tertiary peritonitis is the threat in ICU patients, caused by low-virulence opportunists surviving initial treatment. The physical examination provides the final diagnostic constraints. A doughy abdomen indicates tuberculosis, while a feculent odor in the peritoneal fluid confirms a lower bowel perforation. By identifying how the anatomical barrier between the gut and the sterile cavity failed, the clinical team can select the appropriate treatment path to stabilize the patient and restore that integrity.